You are all very welcome indeed at this event, Voices of Autism. I am Michael Rowe. I'm the Dean of the School of Psychology, Family, and Community here at Seattle Pacific University, and it's our school that is sponsoring this event. Our school includes undergraduate programs in psychology and graduate programs in industrial organizational psychology, marriage and family therapy, medical family therapy, and clinical psychology. We have numerous centers and initiatives, one of which is particularly relevant today because it's a co-host, and that is our initiative for individuals with intellectual and developmental disabilities. I'll come back to that in just a moment. The other co-host is the advisory board of our school, which is composed of people of influence in our neighborhood who are committed to the training of next generation mental health practitioners. I'd like to recognize today the board chair, Dr. Tom Wall. Tom, if you'd stand. Dr. Wall is a nationally recognized clinician, a retired faculty member in clinical psychology, and active with the Washington State Board of Examining Board of Psychology as well. Tom, thank you for your leadership. Thank you to you and other board members for your commitment to our students and programs. One other introduction, and then I'm going to sit down and be a learner with you this afternoon. I'd like to introduce to you Dr. Bev Wilson. Dr. Wilson is a professor in clinical psychology. She is also the director of the initiative I just mentioned that is co-hosting today's program. Dr. Wilson and her students are doing cutting-edge research with children on the autism spectrum and their families. A number of Dr. Wilson's students, after completing their Ph.Ds, have gone on to careers in the field of developmental disabilities with a particular focus on autism spectrum, and again, the families that surround those so diagnosed. Dr. Wilson, I am delighted to turn the microphone over to you.
Thank you. We're very pleased to have you here today. And I'm very pleased to have Annette Estes as our first speaker this afternoon. I want to tell you a little bit about Dr. Estes' background. She earned her Ph.D. in clinical child psychology from the University of Washington. I'm going to turn that down. Okay. And is currently the director of the UW Autism Center. She is a research associate professor in the Department of Speech and Hearing Sciences and an adjunct professor in the psychology department at the University of Washington, as well as a licensed psychologist in the state of Washington. Her program of research is investigating potential early predictors of autism, as well as early interventions for children who show those early signs of autism. She's also very interested in the role of families in promoting the positive development of individuals on the spectrum. Join me in welcoming Dr. Estes. Thank you.
Thank you so much for inviting me. I've had the pleasure of working with Dr. Wilson over the last decade, maybe, and this is just another wonderful event. It's great to see everyone here. I'm really excited to be able to share with you some of the recent findings, soon to be published. Many of these findings are right now kind of in press, and they're the result of work over the last, again, many years by many different people, some of the new people at the University of Washington Autism Center are sitting here today, but there have been people over the years who've really done a lot on these research projects, as well as families. The other thing I really want to say is that all of the work here that I'm going to present is from this community. So it is a real pleasure to be able to do research in this state and in this community because of the support that families of people with autism have for the scientific work that we're doing. And that's a very special thing. So I wanted to say that as we start off. Some of the very first signs of autism that emerge and what we can do early on to help people that are showing signs of autism. And oh, there we go. So when can we see autism? So current research on early identification and what can we do, research on early intervention, and some new work on long-term outcomes of early intervention. And then I'll say a few things about putting this research into practice, because I think the ultimate purpose of all this is to try to affect change more broadly. Okay, so you all probably know this, but just to give us all a common groundwork here, autism spectrum disorders are now defined in the Diagnostic and Statistical Manual, number 5. Oops, should have a number 5 instead of a V there. And the symptoms of autism spectrum disorder are in the social communication domain and restricted and repetitive interests. I'm assuming that that is something that is familiar to all of you, so I'm not going to go into detail there. As you also probably are all aware, the CDC, the Center for Disease Control, estimates have been continually increasing, and I think this is now up to 1 in 68 children. And this varies state to state. I think what that means is not that, that there are really truly underlying different rates, but that there's different abilities that we have in different communities to assess the incidence and prevalence of autism. And I think one of the things I think that we're seeing here with this increase is the increased ability that we have to identify autism spectrum disorders, both earlier and in people who are not intellectually disabled. And this is kind of a change over the last 20 years that I think is a big improvement in our work. The other thing is there's more males to females affected. And the onset of the symptoms we know are prior to 3 years of age. And again, intellectual disability estimates are 40 to 70%. That's a big range. But I think people now are understanding that there are probably the lower rate of intellectual disability is more accurate in the autism community in general. So here's the problem I want to try to talk about today in the most general terms. So we know that autism spectrum disorders can be reliably diagnosed by about 2 years of age, and sometimes even before 12 months of age, and I'll talk to you a little bit more about that. However, the average age of diagnosis in the US is 4 to 6 years old. So clearly that can be a 4-year gap from initial symptoms of autism spectrum disorder to the first diagnosis of autism. And oftentimes there's over a 1-year gap between the first time a parent or a child has a contact with a professional and actually receiving the diagnosis. So there's a big problem that we're facing, I think, as a society here right now in trying to make that gap a lot narrower. The other thing is that once a child gets diagnosed with autism, they often don't have access to high-quality, evidence-based early intervention. And these are some of the things we're trying to change. So to start, I'm going to talk about when can we see autism spectrum disorder symptoms first emerge. So in the second year of life, from 12 to 24 months of age, there are a number of symptoms that have been identified from a variety of research groups across the country. In the social domain, I think most of you who've been around babies notice that they often look at people. They might initiate interacting with people and keep that interaction going with various behaviors, cute things they do, vocalizing, all sorts of things that babies do to keep that social interaction going. And what we see with 12 to 24-month-olds who are going on to develop autism is a lot less of this. So this, and I use the word less kind of repetitively there because I wanted to make the point that it's not a black and white or either or kind of situation. It's not that babies who are going on to develop autism don't interact at all, don't orient at all, don't engage at all. It's that they do it a lot less frequently than children who are going on to develop typically. In the communication domain, there's limited use of gestures, and some kids show delayed language milestones, but at 12 months of age, there's not a lot of language that one would expect anyway. So you have to be looking a little bit underneath the hood there and thinking more about gestures and other forms of social communication. A new area that we now know is actually different as early as 12 months of age is the repetitive behavior domain. So I think up until very recently, people thought that the repetitive behaviors that often accompany autism don't really emerge until around 3 or 4 years of age, but we now know that's not the case. In a study that I'll describe to you in a minute, we found that repetitive behaviors are present, but they're very mild as early as 12 months of age in children who go on to develop autism. And they're particularly evident around repetitive play with objects. So that children who are going on to develop autism might spend more time with objects and might use them more repetitively than other kids. So the study that I'm going to talk a little about is called the Infant Brain Imaging Study. It's actually a network of research centers across North America. University of Washington is one. It's headed by Joe Piven at North Carolina, Children's Hospital at Philadelphia, and McGill University, University of Alberta, WashU at St. Louis, and University of Utah are all working together on this project. And what we're doing, well, let me tell you a little bit about the background here. So one of the first things that I want you to understand about is that infants with older siblings with autism are at higher risk for developing autism than the general population. And there's been a number of groups that have studied infants with older sibs with autism and found that the recurrence risk for infants that have an older sibling is about 20%. In addition to that 20%, the 30% of siblings will go on to have other learning or developmental difficulties that are not autism per se, but are clearly part of the autism spectrum. So 50% of infants with older sibs will have some kind of developmental need. So one of the ideas of the IBIS study and of other researchers in this area are to assess and monitor infants who are at risk and study before symptoms emerge how these infants are developing. So the IBIS research design is to do a developmental evaluation and a brain imaging study at 6 months, 12 months, and 24 months of age. Now the brain imaging study is done at Children's Hospital by researchers at University of Washington, and it really what it involves is getting babies to fall asleep in the scanner. If any of you have ever had an MRI, you know that they're kind of loud. But if any of you have had a baby, you know babies like to be going to sleep in cars, right? And that can be kind of loud. So we're thinking maybe this is why we get all these babies to fall asleep. We also outlast them. And we give the families, based on these two sources of information, clinical feedback and reports that kind of explain to the parents how their child is developing. And I apologize, here's some data for you. So what we have, what I'm going to describe to you is a sample of 222 infants who are at high risk for autism due to having an older sibling with autism, and 107 low-risk infants, or infants who have typically developing older siblings. And these are from the four of the sites I just described, including University of Washington. And of the 222 infants that are at high risk, 49 of them went on to develop autism at 24 months of age. And of those 49 infants, 31 of them had the highest level of symptoms. This is kids who qualify on something called the ADOS for autism, so the highest, most severe level of symptoms. 18 also met criteria for autism, but they had more moderate levels of symptoms. And then 161 of those infants did not meet criteria for autism at 2 years of age. Of the low-risk infants, 4 went on to develop autism, and 98 did not develop autism at 24 months of age. And we, because this group was so small in the data I'm going to show you, these kids weren't included for right now. We're still collecting more data though, so we'll see later. And just to jump to the conclusion here, what we found is that developmental differences may emerge before 12 months of age in the infants that go on to develop autism. Even as early as 6 months, we were seeing some differences in motor development and nonverbal problem solving. So let me show you how we knew this. The first is, this is the Mullen Scales of Early Learning. It's kind of like a baby IQ test. It is standardized and has norms that are based on many infants of different ages. And it assesses learning across visual reception, which is kind of like nonverbal problem solving, expressive language, what you can say, how you're communicating, receptive language, what you understand or from other people, fine motor, which is using your hands to manipulate objects, and gross motor, which has to do with walking and sitting and those kinds of things at the earlier ages. And here's some more data. So bear with me here. You're going to see about 4 slides like this, so it's worth following along. Here we have those 4 groups that I just described to you. The first group, these are in red, are the children who went on to develop autism. In kind of the brownish color are the children that had the autism spectrum or the moderate level of symptoms but still did have autism at 24 months. Here are the high-risk infants who did not develop autism, and here are the low-risk infants who did not develop autism in blue. And this corresponds to the ages, so this is 6 months, 12 months, and 24 months of age. And statistically speaking, what we found in terms of gross motor development, so walking, sitting, trunk control, that kind of thing, is that 6 months of age, the children who developed autism were already statistically lower than the kids that did not develop autism. And this difference increased over time, although statistically speaking, I guess this wasn't significant in this case, and that's because at 12 months things kind of changed a little bit. Anyway, that's probably not, it's just sort of statistical noise there. But we also saw this similar pattern in the visual reception trajectories. So again, the kids who went on to develop autism in red, autism spectrum in brown, high risk non-autism in green, and low risk non-autism in blue. And what this shows is, again, at 6 months, statistically significant differences between the groups, and those differences increased over time. The Vineland is a measure that parents fill out. They tell us how their children are doing at home and in the community, kind of giving a window on development that we don't see as clinicians in the research lab. But it's some similar kind of areas: communication, social ability, daily living skills, and motor development. And what we saw here was, again, the similar pattern. So on the composite, that's all those subdomains together. The kids who went on to develop autism in red, spectrum, high risk non-autism, and low risk autism are showing the same patterns where the groups differ over time. Those differences increase from 6 to 24 months, and those differences are statistically significant at 6 months. And interestingly, when we look at which subdomain is really driving that composite score difference, it's the motor domain. So this is kind of converging evidence from parents that support what we saw as clinicians on the Mullen scale. And interestingly, these same differences were also seen on our brain imaging scans. So this is a study that the IBIS group published a couple of years ago now, or a year ago, I guess. And what this shows is the connections between different parts of the brain at 6 months of age. And these areas that are in red and yellow are significantly different in the kids that go on to develop autism that's what that's showing, from the kids that don't go on to develop autism. So in this case, because fewer kids can successfully kind of get good data for their brain imaging scans, we kind of lump together the autism and the autism spectrum groups. So we have high-risk autism as compared to high-risk non-autism. So at 6 months of age, we're really seeing differences already. Now the trick is, I think, that these differences are statistically meaningful, but they're not kind of things that you could see necessarily in an individual if they came into your office as a clinician or if you were a parent. Now, some parents tell us that they knew from the very beginning that something was different about their baby. So we know that there are some kids who show very, very early signs, but we haven't yet, as researchers, been able to figure out, exactly what that is, and we're still trying to kind of track down that signal and come up with something that is clinically helpful to us. And the purpose of this is to figure out what we can do then with this information. And I think, this is probably the next logical step, once we know that someone is at high risk for autism, is to figure out what we can do in terms of early intervention. We know that early identification can lead to early intervention if our communities are geared up and have the services ready, and that this can lead to improved outcomes over time and reduce autism symptoms in children. But I say that we know this, and yet when I look at the literature, now this may have changed in the last couple months, I don't think so though, when you look at comprehensive early interventions, so these are interventions that really try to move the needle in development across a range of areas, so not just joint attention, but joint attention, communication, social interaction, repetitive behavior, so these comprehensive intervention approaches. I was looking for comprehensive interventions that had been subject to randomized clinical trials. So this is where people come into this study and are randomly assigned to different interventions or to community intervention as compared to the experimental intervention. And as it turns out, there's only 3 studies that have really addressed this question, at least as of a couple months ago. And I'm going to tell you about one of them that was conducted here at the University of Washington, again with our wonderful community of families. And this is the Early Start Denver model. Jerry Dawson, who's the founding director of the Autism Center, and Sally Rogers, who's now at the Mind Institute, really developed this intervention and have published both a book about this and a curriculum that can be used by practitioners. But the Early Start Denver model I should say, is not just the curriculum. It is also an approach of specific teaching practices that are used and are really adapted to very young children. So one of the, and can be used, I would also say, across different environments. So, toddlers and young children interact all day. They interact one-on-one, they interact with groups, they interact with peers, with adults, and so the idea here is to embed infants who have autism or who are developing autism in highly enriched environments that are working really hard to address their specific developmental needs. So, you can imagine that talking about this treatment model, we could be here for days. So I will skip over that very large topic and just get to the data. Let's see, I'm not sure how much longer. Okay, yes, I will definitely do that. And we can come back to that at the end if we have more time. But again, I always skip to the punchline. What we found here is that early intervention can improve outcomes for children with autism. And I will tell you how we know that. So, this was probably maybe 10 years ago now, maybe a little less. The first sample of kids was recruited, 48 toddlers with autism between the ages of 18 months and 30 months, started this project. And these kids were randomized either into Early Start Denver model or community intervention as usual. And I will, again, jumping to one of the conclusions, back then there really wasn't comprehensive autism-specific intervention widely available for kids of this age. And I will just tell you that we did a follow-up study that had the same design, community intervention as usual. And what we found, just maybe, I don't know, a few years ago, was that our community now has a tremendous capacity to serve these kids. I mean, it's not as available as it should be, this kind of intervention, but we really have changed the face of autism, I think, in our community over the last 10 years. So that was great. It also really messed up our research in a great way. We were happy about it. But you know, we found that the control group was really improving as well. So yay, we're out of business in doing those kind of research studies anymore. We have to do a different design. So these kids were provided with annual diagnostic and developmental evaluations, and then the ESDM group got 20 hours a week of in-home one-on-one intervention and 2 parent coaching sessions per month. And the community group got individualized recommendations, early diagnosis, obviously, and then pursued those interventions in the community. And this is kind of old data from the journal Pediatrics in 2010. What we found was that in the ESDM group, significant increases in kind of this baby IQ test I was telling you about, from 61 to 78. And then the community group improved also, but not as much, and it was a significant difference after 2 years. The diagnostic outcomes were also kind of less, well, I would say, I'll say this, that, where am I? Okay. AD is autistic disorder, PDD-NOS is pervasive developmental disorder not otherwise specified. That's from DSM-4. And essentially, this is a more severe set of symptoms that kids in the autistic disorder category demonstrate. And you can see at baseline, 21 kids had autistic disorder, 3 PDD-NOS. Here we had 18 and 6. And then 2 years later, after the intervention, what we see is that 7 kids now were in the PDD-NOS category. So 7 kids had gone from autistic disorder to PDD, and only 1 in the community group had shown that kind of lessening of severity. So that was these are just a sampling of the results. So overall, there was an improvement in IQ, improvement in communication, reduced diagnostic severity for the kids in the ESDM group. And the study that I just completed and is going to be published soon, I think, is a long-term follow-up study of that same group of kids. And this is when they were 6 years of age. And we wanted to see whether the gains that were made during early intervention were sustained or whether they diminished over time. And that's something that actually has not been studied. Again, really surprising, right? But the only other study that we could find was McCacken, Smith, and Lovas did a long-term outcome study of their seminal work that established ABA as an effective treatment for autism back in 1980, mid-80s, and they did a long-term follow-up and over 20 years ago with 19 kids, and they showed that there was sustained gains in that sample. But nobody's done this since then, so go figure. I don't know. So what we found in these same kids that I just described, well, actually not quite the same. There were 39 kids that were available to follow up, so we lost 3 kids in that intervening several years. So we assessed the kids at 6 years of age, and the kids were assessed importantly by people that didn't know which group the kids had been in before. So they didn't have that bias going in. And here's a little timeline of the study. I don't think we need, I don't know. Anyways, you can see that we saw them again at 6 years of age. And here's a ton of data, but what you can do is focus on the thick lines. What this shows is the cognitive changes from age 2, 3, 4, and 6. So again, 2, 3, 4, and 6. The ESDM group is in blue, and the control group is in red, and I think, oh good, I have a simpler version for you to focus on here. And what this shows is that at age 2, or that's the average age, at 18 to 30 months, there were no differences in cognitive ability between the groups. And then over time, those differences widened with the ESDM group gaining, and this is what I just went over, published in 2010 in Pediatrics. And then both groups continued to increase their IQ over the next 2 years. So this is at age 6. So you can see the ESDM group improved. The control group improved a little more, and the variability increased tremendously. So some kids really took off. Other kids really didn't show the same kind of gains. And so at this point, there wasn't a statistically significant difference between the groups. So a statistically significant difference that existed at age 4 doesn't exist anymore at age 6. But we'll give the credit there to the control group who really did show some nice developmental gains. But conversely, autism symptoms, this is assessed by the ADOS, which is a semi-standardized assessment of communication and social ability designed to help in diagnosing autism. And you can see again at age 2, there was no difference between the groups. Not surprisingly, they were randomized. There was a little difference at 1 year of age with the ESDM group showing a little decline in severity, which you want to see. But at the end of the ESDM trial, that paper I was just telling you about in 2010, there was no statistical difference, and really no difference between the groups in terms of their severity of symptoms on the ADOS. But 2 years later, there's a really significant difference where the kids that had that early intervention with ESDM were significantly less severe overall in their symptoms. And the kids that were in the community group really stayed about the same over those 2 years. And we're very interested in this because we didn't intervene with the kids during those 2 years. What we think happened was that the kids in the ESDM group who had had that early intervention were more able to participate in community kind of, not only therapies, but just even regular kind of social interactions that kids would have at that age, and continued to show improvement after the intensive intervention had ended. The other thing, you might want to know about, this is that data I showed you before. At 6 years, we have 2 kids in the early Start Denver model group who did not have any signs of autism anymore. So these are 2 kids who are clinicians who are trained to detect autism and diagnose autism, didn't think these kids had it anymore. And their IQ scores were in the average range. They were in regular education classrooms and were really, one child had some support services, but for the most part, they were really indistinguishable from their peers. Okay. And this was all happening in a context of other interventions, right? So families either ended the ESDM study or they continued on, getting community intervention and being part of our school systems. And what we showed here is that 4 years of age, the community group was getting about 9 hours a week of one-on-one intervention. Over at 6 years, they were getting about 7.5 hours a week of early intervention. Or of one-on-one intervention, sorry. In the ESDM group, they went from 15 hours a week to 4 hours a week of one-on-one intervention as a group. So this is the mean of the groups. That's a really significant drop. And if you remember back to that IQ Mullen scale slide, those increases in both these groups are happening in the context of seriously reduced one-on-one interventions. And the other interventions, this is like speech and language therapies, OT, other things that people do. The ESDM group was getting about an hour and a half a week as compared to 3 hours a week in the community group. And interestingly, in group settings, the ESDM group was 41% of the time were in group settings rather than one-on-one in these other interventions. So the ESDM group had fewer total hours a week of other interventions. They spent more time in groups. And we think that the context is important, so that the kids were showing these gains in less intensive interventions than they had before. So in summary, we think early intervention may have lasting effects. Certainly the gains were maintained and in some cases were increased 2 years after intervention. And and it was just an interesting pattern to see that the autism symptom severity continued to decrease after the trial was over, while there was less intervention. And we were really happy to see that the community intervention group did continue to make gains over those 2 years after the trial. So again, I think our community has a lot of great therapists, and we're assuming that they're accessing that wonderful community. So what we need, the parents that were involved in this were on average quite highly educated, high resource families. They had to be within a half an hour of the university, or we wouldn't have money to go to their house 20 hours a week. But we really need to do more research that reaches out to less educated, lower resource, rural, military, other communities, because that's sort of the next step, I think, in the research that we're doing. Let's see here. Yes, the families were amazing. And so the last part of my talk, I just want to focus on what we're trying to do now, bringing the research that we've been doing into the clinic. So I just started as director of the Autism Center a little over a year ago. And, I've been spending 10 plus years doing all this research, and here is a wonderful opportunity to take what we've learned from the families that have been in the research projects that we've been doing and try to make that kind of thing available to our to people that are coming to our clinic. So we at the Autism Center, we're focusing on clinical service, research, and training. And to bring research to practice, one of the things that we just recently launched is an infant clinic. So you can imagine that we have talked to a lot of parents now who have infants who have older sibs with autism. And what they told us is they found it really helpful to have that assessment and monitoring in those first 2 years of their infant's life, because they knew that their infant was at higher risk for autism. And they wanted to, be working with professionals along the way to make sure their child was on track developmentally. So what we're doing is we're assessing and monitoring development in infants at risk, and they don't have to have an older sib for this clinic. Parents can just say, hey, I'm kind of worried about autism in my baby. Can you guys take a look? And we certainly do. We've had about 10 parents now come in with their babies. And our idea is that we want to have a seamless transition from the first signs of autism symptoms emerging to intervention. We don't want to have any wait time, and we want it to not need to reach a level that a child has severe needs. We want to catch these things early on before things kind of have gone on for too long. So in addition to that, we have a ABA-based clinical services, and this is inspired by the Early Start Denver model, so it's very much developmental applications of ABA, but kind of a hybrid of approaches. And what we're doing is providing, this is what people are doing, hopefully in many communities, but providing individual in-home programs as well as in our clinic. And we're developing a team of paraprofessionals who are ready to help parents in the home. So one of the things that parents often are faced with is they get a diagnosis, maybe even really early, which is great, and then they're told, okay, you need intensive in-home intervention, and go for it. And there's a big gap there for parents between, even if they know what to do, how do you get a team of people together who know how to do this kind of work with their child? And so not only do we have the kind of higher level BCBA kind of trained people, but we also have paraprofessionals who are ready to go into the homes and do those programs with the kids. And then the parents, because this is a kind of high demand service, we work with the parents to also get their own team going sort of during that time, so kind of bridge that gap for people. We also know that so we want to support parents as they build their team. We're starting a training for registered behavior therapists, and we want to be able to help parents who do have sort of independent teams going by providing them with supervision for their therapists and home programs. So a little bit of a menu option for people. We also have a summer camp that's based on an evidence-based program that was actually initially designed for kids with ADHD, but we've kind of translated it into working with autism. It's going strong, and we've developed a weekly booster camp over the year. So this is fun camp-based activities, really, if any of you have had kids that go to summer camp or have went yourself, that's the kind of thing that we do. We play games and have fun. But what the goal is so that kids can really participate in those kind of sports and recreational and fun activities with their peers all throughout the year. So, on the playground at school, on the weekends with friends, that kind of thing. We also have a new direction, which is a pilot program teaching 12 to 16-year-olds to play a game called Magic the Gathering, which any of you who have teenage boys might know about. I certainly do. I spend a lot of Friday nights trekking to these games that are really one-on-one and wonderful ways to socially interact, but with a kind of structure around it. So that's one of the things that we're working on now, too. We're also working to develop a center that we have in Tacoma. We have a new director. We have 2 clinicians down there. And our goal is to really increase services in this sort of more underserved areas of our state. And then, of course, we can't do it all by ourselves. And this is one of the things that makes me be able to sleep at night, is that we really can't serve each child who develops autism, and that's not our goal. Our goal is to increase the capacity of our community to serve people with autism. And one of the ways that we're really happy to be able to do this is this summer, St. John's Masonic Lodge sponsored us to do a training free for school teachers. So we can have up to 1,000 teachers and educators in Kane Hall at UW, and invite your friends, tell everybody. It's our goal is to also have free parking and free lunch. So we really want to make sure that people have access to this, and it'll be 2 days of workshops and strategies for educators, hands-on kind of things. Well, we do a lot more, so go to our website if you want to see that kind of thing. But anyway, so that's kind of the story. We're trying to develop comprehensive services that really are responsive to the needs of families and very young children. And we'll see. Yes. Great, thanks. We do. We have some time for questions if people want to ask. Yeah.
One of the things it does is look at the parallel between behavior and movement patterns. And so I wonder, when you're looking at younger siblings, if you try to tease out whether that correlation is genetic or is a learned behavior from older siblings.
Okay. The question is whether younger sibs who are showing some of these early signs are learning these kind of behavior patterns from their older siblings, or whether it's kind of, or in part anyway.
The younger siblings
Mm-hmm.
do they then pick up behavior patterns the same way?
It's really a question that a lot of people have had over the years. Are younger siblings learning this or not? And I think in general, I would say no is the big answer, because, obviously kids with autism, one of the core deficits that kids with autism show is the ability to learn socially, naturally, easily from other people, right? I mean, so I think that and we know that autism is neurobiological, that some of the delays that kids show really wouldn't be something that they would learn. That said, are there some things that kids pick up from their siblings? Probably, yeah, but I wouldn't say that autism per se is something that is learned. It's neurobiologically based. Maybe I didn't answer your question, but Anyway, that's,
The question is, have you tried to tease it out?
have we tried to tease it out? Yeah, we probably haven't done as much as we could that way, because now that we have this incredible data set, we're kind of going for the big question, the first questions first. But yeah, one of the next questions is what about the siblings, and how are, is an older sibling that's more severely affected more likely to have a younger sibling that's more severely affected or not? Those kind of questions. We really haven't had a chance to dive into that yet. Yeah.
I had a question about the sibling study as well. Were all the sibling pairs full siblings, or were there any half siblings? And if they were half siblings, did we discover anything about that?
We only had full siblings, and that was simply because we know that autism is largely, or a large portion of autism is heritable, and so we kind of wanted to enrich our sample for that. But I think the half sibling, full sibling question is been addressed in some other genetic studies over the years, and it's really been the basis for why we knew that autism was genetic. So I think Patrick Bolton back in the 90s did a fabulous study of siblings that were monozygotic twins sharing, full, all their DNA, dizygotic twins sharing about 50%, and then, kind of on down the line, cousins, that kind of thing later. But those MZ, DZ twins, there was a really big difference in how many, like if you're a monozygotic twin, in his sample, I think it was 90% of the kids, those twin pairs both had an autism spectrum-ish diagnosis. Dizygotic was like really low in that sample. So that really gave us some very strong evidence for the genetics of autism. So so there have been a lot of people who've looked at that over the years.
Have you tried neurofeedback as an intervention?
We haven't tried neurofeedback. It's a great idea. I mean, I think, some of these, especially as kids get older, a lot of kids show signs of anxiety and stress, and we haven't found all of the creative ways of helping people address that. So no, we haven't done that work, and I don't know if others have, but certainly lots of creative ideas out there that should be looked at. Yeah.
Your intervention for age 4 to 6
Mm-hmm.
indicated that you intervene once every 7 days or something like that, you said. What is the data on the parents? 4 to 6, what happens to the parents? You mentioned education, but what happens to the parents? Impact on the parents doing it?
Okay, 2 questions there. One, I apologize if I was unclear on the age 4 to 6. I think this is the first time that I've presented that data, so I will thank you for giving me a second chance. I think from age 4 to 6, the intervention study proper ended, and people went into the community and sought out intervention sort of spontaneously, or the parents were the ones driving that. They decided, I think my child needs more one-on-one, I think my child needs more physical therapy. So it was all very parent-driven during that time. And we did our best to ask parents what they were doing with their children, but really we couldn't directly kind of compare, because one physical therapy is not really comparable to another physical therapist approach. So what we did was we did our best by putting things together in terms of hours that people sought out in kind of broad categories. So there's that part of the answer. You had a second question, is what is the impact on parents? And I didn't present this data. We've done several studies on parent-delivered interventions for kids with autism. And the first study that we did, I think it was published in, I don't know, the year 2012, I'm thinking. Sally Rogers was the first author. And in that study, what we found was that short-term, so 3-month, low-intensity, approximately 1 or 2 hours of intervention a week, parent-delivered intervention was not sufficient to significantly change the developmental trajectory of children in our parent coaching group as compared to community intervention. Now, one of the important things about that was that the kids in community intervention got 5 hours a week of intervention, whereas our families got 1. And so, maybe the fact that they were still on par at the end of 3 months was good. But also what we really took away from that was 3 months is not enough. Parents are incredibly important, don't get me wrong, but I don't think that in most family situations, parents are going to be able to deliver the intensity of intervention that a team of people are, provide in, say, our randomized clinical trials. I mean, it just, kind of makes sense looking back. But one of the things, so we've done other studies to try to improve our ability to teach families effectively, because I think that's the other thing that, we have to look at ourselves and say, okay, well, what can we do better here? And we've developed some new approaches that way. But I think the main thing that I was really happy about with this, and I think, I don't remember the year, sorry, but I published a study with Sally that looked at, or Rogers, Dr. Rogers, that looked at the effect on parents in terms of parent stress and sense of competence. And what we found was that the parents that did this parent coaching in that 3 months later, the parents in our parent coaching group had lower levels of stress than the parents in the community group. And I was really happy about that because I feel like, that's our goal. One of our goals here, not only do we want to improve the children's developmental trajectory, we want to make sure that the parents are being supported adequately and that our interventions aren't actually making things harder for people, parents and families. So we were happy about that, even though the children didn't show any differences. Yeah.
We're having a problem with schools, so you go as far as parents, but forgetting schools.
Mm-hmm.
And the schools are afraid of getting sued by the parents. That's because they're funding. But what can you do to get you to go further in?
Yeah, so early intervention makes you kind of yearn for more, right? I mean, what the comment here is, what about the schools? And, this is a great segue into Dr. Stobie's talk, because babies become school-age kids, school-age kids become teenagers, and teenagers become adults. And then people spend most of their life being adults, so I think that really early intervention is one piece of the puzzle. But certainly, so we're trying to also address things like by training teachers. We do lots of that kind of thing at the Autism Center, and I know other people do too. But yeah, there's, a whole lifespan approach is really important, and yeah.
It's working. I just wanted to know, how prevalent would you say the knowledge is about this really early diagnosis? I'm a speech pathologist, and I've referred kids that are pretty young out for these evaluations. Parents have been told, no, don't think anything's wrong, and then a year later, they're told, yes, your child has autism. So, it's only happened about 3 or 4 times that I can remember, but I have a couple kids on my caseload right now that have just gotten back from those evaluations. And so I guess I'm wondering, I'm hoping to contact those professionals and say, well, this is what we're seeing,
Mm-hmm.
but it's hard once parents hear that. It's
tough because, there's 2 things about your question, I think. Well, one, I'll tell you a story about our very first child that came to our infant clinic, and a lovely close colleague called me up and said, okay, Annette, I know that kids under 12 months of age can't be diagnosed with autism, so I know that you don't think I'm crazy. She was really like, okay, she's gonna really think I'm nuts here, but could you take a look at this little guy? He's 10 months old, and I'm worried about him, and I've been seeing him since he was 6 months old, and the mom really thinks he has autism. I know that's not possible, but, can you take a look? And he came into our clinic 10 months old, and he met full criteria for autism. And obviously, being able to diagnose a child that young requires seeing a lot of babies. You have to really know infant development, typical infant development, to know when infant development isn't quite on track. So I think it is a bit of a specialty. I don't know that, we want everybody to, in our community, to have the skills needed to kind of diagnosed, we would love that. But I think, probably realistically, you have to see a ton of babies, and if you don't, then it might be hard. But yeah, so I think it reminds me of, back in the 90s when I started as a postdoc with Jerry Dawson. I was calling up people. We were doing a family study of autism, so families with 2 or more kids with autism, and I talked to a pediatrician who said, it's impossible to have 2 kids in the same family with autism. Lightning does not strike the same place twice, you little postdoctoral fellow, you. And I was kind of like, well, we're doing a whole study on that. I don't know, But anyway, so we're kind of, we're moving along, and I think eventually our data isn't that old, right? Or it's still newly developing story that we have, but yeah. So I think we're getting there, but yeah.
You've anticipated my question. To what extent are pediatricians being trained to identify the early symptoms and signs of autism?
Well, Dr. Sobey maybe can talk more about that too, but I think there's a lot of efforts. That Wendy Stone, I know, had a really nice program to reach out to pediatricians. There are, I think there's more we can do, and I will probably let Dr. Sobey talk more about that. But yeah. Okay.
So we have cookies out.
Cookies.
Right out there.
Okay.
Cookies are very